7:29 தான் இருக்கு போல இருக்கு சார் இல்ல?
Maybe anybody to join?
Preeti has to
Faculty
join,
side.
sir. Preeti ma'am has to join. மீதி பேர்லாம் கூட லேட்டா ஜாயின் பண்ண பரவாயில்ல.
Dr. Hema Nandini.
You are live now, doctor.
Okay. Right. So we'll start now. Right. Good evening, everyone, and welcome all of you for this TNOA Thursday program. So today's program is a meticulously curated postgraduate update program called Ophthalmic Horizon. So this is case presentation to benefit our young postgraduates and younger ophthalmologists. So as a community dedicated to the pursuit of excellence in ophthalmology, we are here to engage the young postgraduate with the senior professionals to discuss complex cases and get their expertise and share their collective wisdom so that our knowledge in ophthalmology grows towards excellence. So let me welcome all of you for this unique program, and thanks to our moderator, Dr. Sharmila Devi, and our panel of distinguished examiners, Professor Hema Nandini, Dr. Preeti Uday, Professor Yogeshwari, and Dr. Batma Priya. So welcome all of you. I would also like to acknowledge the presence of my good friend and Professor Vijay Shanmugam. Welcome, Vijay. Dr. Sendil Nathan.
Thank you, sir.
And Professor Periyanagi for accepting our invite and being here to share their experience and expertise with the postgraduates. I'm thankful and welcome all the managing committee members and senior office bearers and senior members of TNOA to this program. I should congratulate and welcome Dr. Sushmita, Dr. Sukanya, and Dr. Lavanya, who has boldly come forward to present the case. It's quite difficult in an online forum exposing your knowledge as well as certain key areas to everybody so that everybody learns. So I appreciate you and welcome you to this program. So I'm sure your discussion will be useful to not only to you, but also to all the postgraduates who are viewing this program, and also will be a good resource material for PGs taking up exams in the later part of your curriculum. So with these few words, I thank the moderators and particularly our convener, Dr. Sharmila, for taking the initiative and curating this program. Thank you, Sharmila, and welcome to this. Over to you to take over and take care of the program. Sharmila, you are muted. Unmute yourself, please.
Good evening, everyone. On behalf of TNOA, it's my pleasure to welcome all the teachers from the esteemed teaching institutions, Professor Hema Nandini ma'am, Professor Vijay Shanmugam sir, Dr. Periyanagi, Dr. Yogeshwari ma'am, and all the eminent orbit and oculoplastic surgeons from the corporate hospitals. So we have a mix of both the government as well as the corporate teaching side. So the first presentation will be on proptosis, and this webinar has a very good view. Every webinar has about more than 1,000 views. So this is one of the most popular programs among postgraduates, and we are hoping that this webinar too is of use for all the postgraduates. So we have 2 orbit cases and 1 uveitis case today. The first case is proptosis. Dr. Sushmita from Tanjore Medical College will be presenting the case, and the examiners for that case will be the Professor Vijay Shanmugam sir and Dr. Preeti Uday. Over to you, Dr. Sushmita. Thank you, Nirmal sir.
You're welcome, Sharmila. Thank you.
Shall I start, ma'am?
Yeah, please do.
Sharmila, time?
So half an hour for each case, sir. After she finishes, we have 25 minutes to 30 minutes for discussion.
Oh, thank you. Sushmita, 10 minutes,
Yes.
your presentation.
Yes, sir. Good evening, all. I'm Dr. Shushmita, final year postgraduate from Tanjore Medical College. A 63-year-old female came to our OPD with complaints of prominence of left eye for the past 1 year and defective vision in left eye for the past 6 months. History of presenting illness. Patient was apparently normal before 1 year, after which she noticed prominence of her left eye, which was insidious in onset and progressive in nature and not associated with pain. No history of postural variation, no variation in size while sneezing, coughing, straining. Complaints of defective vision in left eye for the past 6 months, which was painless, insidious in onset, and progressive in nature. No history of double vision, redness, discharge photophobia, increased sweating, tremors or palpitation, weight gain or weight loss, cough or blood in sputum, headache, nausea, and vomiting. No history of trauma, nasal obstruction, or bleeding from nose. Past history, no history of any systemic illness. History of left eye cataract surgery was done before 1 year. No history of radiation therapy. No history of similar illness in the past. Personal history, patient is on mixed diet. Bowel and bladder habits were normal. Family history, there was no history of similar illness in other family members. General examination, patient was conscious oriented, well-built, no pala rectus cyanosis, clubbing and lymphadenopathy. Her vitals were normal. The systemic examination was normal. No tenderness in paranasal sinuses. Neck examination was normal. Breast examination was normal. The profile photo of the patient. Now going to ocular examination, the uncorrected visual acuity in right eye was 3/60. IOP at primary gaze was 16 mm Hg and at up gaze was 17 mm Hg. Fields was normal in right eye and color vision was normal. In left eye, the vision was denies PL and IOP at primary gaze was 18 mm Hg. IOP at up gaze was 18 mm Hg. Fields and color vision could not be assessed because of poor vision. Proptosis evaluation, inspection, head posture was normal. There was no facial asymmetry. On Hirschberg test, it showed left eye eccentric proptosis. The inlets, there was no discoloration, engorged or dilated veins, pigmentation and edema. Nafziger sign was positive in left eye. The left eye corneal apex appeared first. No variation on bending down or Valsalva manual. Scleral show was present inferiorly in the left eye. Hirschberg test showing eccentric proptosis in left eye. Nafziger sign was positive. Palpation, no warmth and tenderness over the closed eye. Orbital margins were intact. Finger insinuation was possible in all the quadrants. No mass was palpable or not compressible or reducible. Resistance to retropulsion was present. No thrill or pulsation was present. Auscultation, no bruit was felt. Right eye, the anterior segment findings were normal. Pupil showed 3 mm, round, reacting to direct and ill-sustained to indirect light reflex. Lens showed immature cataract. Extraocular movements was full and free in all directions and orbital margins were intact. In left eye, there was inferior scleral show. Lid closure was adequate. Bell's phenomenon was normal. Conjunctiva was normal. Cornea was clear. Sensation was intact. Anterior chamber, normal depth. Iris color pattern was normal. Pupil showed relative afferent pupillary defect and reacting to indirect light reflex. Lens pseudophakia and extreme movements limitation was present. Orbital margins were intact. This shows the extraocular movements with the limitation of extraocular movements in the left eye. Two ruler method in right eye, horizontal measurements was 30 millimeter and in left eye it was 35 millimeter. Vertical was 10 millimeter and in left eye 13 millimeter. The distance from the lateral orbital margin to the apex was 17 millimeter in right eye and left eye 26 millimeter. This shows the distance from the lateral orbital margin to the corneal apex in right eye and left eye. Fundus examination, right eye, the fundus was normal and in left eye, the disc showed palar, vessels was normal, macula was normal. The fundus image of the left eye showing pallor of the disc. Provisional diagnosis, left eye, painless, non-pulsatile, chronic eccentric proptosis. Investigations, the total count, differential count was normal. Blood sugar was within normal limits. ESR CRP was found to be negative. The thyroid function test was normal. Chest X-ray was normal. MANT was non-reactive. Serum ACE and lysozyme measurements were normal. CT orbit, axial coronal was taken. Yes, sir.
Nice. Which do you want to be assessed? Sharmila, can I start? Hello?
Yes, sir. Please do start.
Yeah. Because you said you're waiting for Preeti, right?
She's there, sir. She's joining.
Okay.
Yeah, hi, I'm there.
Okay. Oh, good. Nice to see you, man.
Nice to see you too.
Sushmita, in which do you want to be assessed? In your examination or you want your theory to be assessed?
Theory,
you there?
examinations are purely from an examination point of view.
Well, whether she's there or not.
Sushmita,
Yes, sir.
Show me your face. What is your face? Sushmita, you're there.
Yes, sir. I'm here.
Hello, mic testing. Munje kate. In what do you want to be assessed now? In your examination techniques, or you want to be assessed in your theoretical knowledge? Theoretical knowledge. Okay, go back to your photos. Go to your photos. We have 12 minutes. I'll take 6 minutes. Preeti will take 6 minutes. So go to your.
So we have time for another 25 minutes, sir. 20 minutes we have.
Yeah,
you can take 10 minutes.
After. Okay,
yes,
10
sir.
minutes. Or 8 minutes, you remind I'll wind down. After let Preeti take. Photo. Go to the next. Go to the next. This previous photograph, just the photograph you put.
The profile of the patient.
Just put it. You said Hirschberg's, you say proptosis. How do you say Hirschberg's proptosis?
Hirschberg, if the light reflex falls in center of the eye, then it is axial proptosis. If it is not in the center of pupil, then based on that, eccentric proptosis can be ruled.
Yeah. Hirschberg's will tell you there is proptosis or now. What is proptosis?
Prominence of eyeball more than 21 millimeter, or a difference between both eyes of more than 2 millimeters.
Is it prominence? Suppose the patient has got one eye protruding out. You call that proptosis. Or if the orbit is shallow and the eye looks large, you think that is proptosis.
The eyeball is protruding out is proptosis.
So it is coming out, you mean?
Yes,
the normal orbit size or is an abnormal orbit size?
The orbit size is normal, but the orbital contents, due to increased orbital contents, proptosis.
So it has to come out, right? So when you
Yes,
throw your light anteriorly, how would you know it is coming out? Unless you look from above.
In Nafziger's sign, proptosis can be.
Okay, now mind. You asked for theory only. So now the eyeball is down and out, I guess.
Yes, sir.
What do you think can be the cause? Unilaterally.
Unilaterally, frontal mucocele, frontal tumors, osteoma, frontal osteoma.
Okay.
Frontal abscess.
You said frontal mucocele, okay, commonest. Then all the other superior orbital tumors, anything which is above there. Then elderly.
Lymphomas.
Lymphomas will not cause eccentric. Okay. Now tell me the causes of unilateral proptosis in this age group.
In unilateral proptosis, inflammatory causes like thyroid, traumatic causes like orbital hemorrhage, infectious causes like orbital cellulitis, orbital abscess, vascular causes like cavernous hemangioma, and tumors, primary tumors of orbit.
Okay. Now you said all this. Your first will be the commonest, right? So down and out, you said frontal mucocele.
Yes, sir.
And unilateral proptosis, you said first was thyroid ophthalmopathy.
Yes, sir.
How do you differentiate both? Clinically.
Thyroid, mostly axial proptosis.
Sushmita, sorry to interrupt. Can you switch on your video? There are some 1,000 people watching this. Usually, it'll be nice to see
Yeah,
your
please
video as
switch on
well.
your video. I am also looking nice here. So you switch
Yes,
on your
sir.
video, you look better.
Yes. Thank
நானே
you so
வெள்ளையா
much.
தெரியுறேன் இதுல.
Thank you, Sushmita.
Tell it. How do you differentiate both? We have 7 minutes to go.
In thyroid, mostly axial proptosis, sir. With that can be lid signs like lid retraction, lid lag on down gaze.
Frontal mucosal.
Eccentric proptosis.
Where will
There'll
be the
be
mass? You said
down and
finger
out.
insinuation.
Yes, sir.
Where
Supronasal
there'll be the
quadrants.
So there'll be fullness there. If you want to do an investigation, what do you want to do?
CT, PNS.
For what? You
Frontal
have two differentials with you now. The commonest differentials with you. Now you want to do a CT of what? You should ask your radiologist what CT you want. What will you do?
Orbit axial coronal 2 millimeter cuts.
Of what? 2 millimeter cuts from superior to inferior, or you want optic nerve cuts?
Optic.
Sure. Okay, you have your CT with you, I guess.
Yes.
Put the CT on. Come, put the CT up.
CT mix.
Okay, now. உன்னால enlarge பண்ண முடியுமா? Can you?
Yes, sir.
Okay. So read any one thing which you think is important. Read anything. Is this a CT or an MRI?
CT, sir.
Okay. Why do you say CT?
The bone, can see the bone.
You see the bone what? Okay, now they will definitely ask you how to read a CT and an MRI. Okay, any one thing you choose and you tell me. Probably the second line looks nice. Read the third picture or the fourth picture.
This is the CT axial coronal.
Hey, ஏதாவது ஒண்ணுதான். அது என்ன axial coronal? This is an axial or a coronal or a sagittal view.
This one is an axial cut, sir.
Okay, showing what?
The second row showing a well circumscribed intraconal mass of left eye, sir.
Circumscribed.
Yes.
Doesn't look circumscribed. This looks circular or what?
Fusiform shape.
Okay. Fusiform swelling where?
Intraconally.
Intraconally. Why can't you say retrobulbar? Intraconally enga muscle. Can you see the muscles? Medial and lateral தெரியுதா?
In right eye we can see, sir. Left eye.
Okay. Mass extending from where to where? What is the size of the mass? How is the intensity of the mass? Is it pushing the eyeball outside? What is the level of the mass? Do you find any lacunae there? Is it kinked?
The optic nerve kinking is not seen, sir.
Lakin ஏதாவது இருக்கா?
No, sir.
Okay. So don't make rush into a diagnosis with only one view. Go to any other view. இது நீ சொல்றது bone window. That's why you couldn't make out. Go for the X-rays which is down. You can see. Kila. Pull it up. There you can see, no, eyes nicely you can see. Bone window la சரியா தெரியல. Here you can see. 1, 2,
Yes, sir.
3. Third line, second photograph. Second X-ray.
Yes, sir.
This you can see. So now, does your first two differentials fall into this?
Yes. No,
Mucosal
sir,
sonna, how do you think a mucosal would present and how do you think a thyroid swelling would present on a CT?
in thyroid swelling, there'll be EOM, extraocular muscles enlargement with tendon sparring, sir.
For a mucosal?
Mucosal eccentric mass, extracoronary, in the supranasal quad.
Not in this ethmoidal view. It will be high up and you can't see in this view. You have to see in coronal view. Okay, maybe. Here, you get a fusiform mass, right? So now, what could your differentials be now?
Optic nerve glioma.
Okay, tell me about optic nerve glioma. Does this picture fit into optic nerve glioma?
Yes, sir. That's a fusiform enlargement, but there's no optic nerve kinking seen here, sir.
What is the age group? What is that? Does it fit into this age group?
No, sir. Most commonly, it will occur in first decade of life, sir. Here, patient is 63-year-old.
With only 2 years swelling, you said.
Yes, sir. For 1 year, past 1 year.
Oh, 1 year. Sorry. So second decade less. So what can be the other differential? This age group
Meningioma is more common.
Okay, orbital meningiomas you can get. So what could be the features here for orbital meningioma, clinical features of orbital meningioma?
Orbital meningioma, it can cause a proptosis with, if it is a sphenoid wing meningioma, there can be temporal fossa fullness, sir.
Agreed. Then
On
sphenoidal wing, here you can see it as a fusiform swelling in the optic nerve. But here, one thing you didn't notice is the lower cut sections, I can't see the optic nerve.
Yes,
One and cut section, I could see.
Yes, sir.
So this is a superior inner malava. You can't see the optic nerve. So I think
Yes,
optic nerve is bad here. Optic nerve malava swelling, so it is pushing it down. Sir, you can see the optic nerve. Good. So I would like to put meningioma in the age group. Okay, good. What are the radiological signs of meningioma?
There can be tubular enlargement of the optic nerve sheath with tram track signs. Calcification due to calcification.
Tram track sign in axial views and in coronal views, what do you see?
Coronal.
End on view, Patina, what will you see? What will be the surrounding
Erosion.
bone?
Bone.
End on view, yes. You will have one sign, no? Ring sign, something they'll say. You haven't heard about ring sign?
Ring sign.
Look it up.
Non.
Surrounding bone, meningioma?
That can be bony destruction.
Erosion, or you can have hyperosteosis also. So I think it's better because coronal view you can see some superior mass pushing it down in the age group. Okay. Now tell me the triad of meningioma.
Hoyt-Spencer triad, sir. That can be a progressive vision loss, optic atrophy, and optociliary shunt, sir.
So, history, you have missed this in your history. How should your history been?
There will be proptosis followed by vision loss in case of meningioma.
Ketia?
Yes, sir. History I
ஆனா நீ
presented
அதை
like
பிரசன்ட் பண்ணல, நீ முதல்ல அதை சொல்லியிருந்தீங்கன்னா we would have thought of gliomas. First நீ present பண்ணும்போது I was thinking only in terms of frontotemporal leukocyte. Okay.
actually she the prominence of left eye for past 1 year, sir. Then there was vision loss for past defective vision for 6 months, sir.
Okay, 2 more minutes. சரியா? Okay, how are you going to treat this patient now?
After the investigations, and I'll next I'll ask for MRI, sir, to rule out any intracranial extension.
ஏன்பா சிடிலே தெரியும்ல, hyperostosis இல்ல, surrounding இது இல்ல, erosion இல்ல, it is not going there into the brain matter, everything you can see. Why unnecessarily asking for another investigation? How would you going to treat this patient? Are you going to do an extension? Are you going to remove the eye? Or are you going to follow this patient?
If it is intraorbital with no extension, then we can observe the patient and ask for serial imaging and examination, sir.
Meningioma, you want to observe this patient now, huh?
Here,
Is there any of biopsy here?
If the diagnosis is confirmatory, biopsy.
How will you confirm the diagnosis? Biopsy panna confirm பண்ணுங்க. Is there any possibility of biopsy here?
Biopsy is not indeed.
Okay, how would you approach this swelling now? Give me just 1 minute. Preeti, I'll give you the full after 1 minute.
Yeah, sure.
So how will you approach this theoretically? What orbitotomy you can do to reach this? என்ன orbitotomy பண்ணுவ to reach this kind of a swelling, retrobulbar large mass? Anterior. Orbitotomy is also important for you, Shishmita. They will ask you. Suppose neurosurgeon, what is the role of neurosurgeon for this patient?
Intracranial approach.
Intracranial approach, you should know what kind of approach they will do. You think it's better for us to do or a neurosurgeon to do? And do you want to remove the globe or you want to leave back the globe? Because there are certain indications where for aesthetic and cosmetic reasons you leave behind the globe and remove the nerve only.
Since there is
Okay, final question. Suppose I'm going to remove, the neurosurgeon is giving you only the optic nerve. They've removed it, leaving behind the globe, and I put it under the microscope. What would I see?
Sir, not audible.
Suppose it is a meningioma. What would I see under the microscope?
Thermomatous bodies.
Histology is important. Final diagnosis. One very important station is pathology. If you flunk in pathology, you will not pass the whole exam because it's a final diagnosis. Seriya?
Yes, sir.
Okay. I had time to ask questions only. It's up to you to prepare. These are the only questions they will ask you in theoretical aspect. And few, if you want maybe 10 minutes. Preeti, the floor is yours, Preeti.
Yeah, hi. I'm so happy you were not my examiner during PG. So, Sushmita, it's not going to be so tough. I think.
Even I feel the same, Preeti.
So, what I feel is as a PG, you need to examine well and give the differentials. Okay. Only as a fellow, you will need to know more in detail. So, for you, examination of the case thoroughly is the utmost importance. Okay. Now, in this patient, you need to tell me correctly whether it is axial or eccentric proptosis. Quick answers.
Eccentric proptosis, ma'am.
Eccentric proptosis. And in the scan, where did you see the tumor?
It was retrobulbar.
So retrobulbar space is what space in the orbit?
Intraconal.
Intraconal. So if intraconal lesion, what kind of proptosis it will cause?
Will cause axial proptosis, ma'am.
Yes. So now there is full confusion, right? It's not
But-
matching. You're saying eccentric proptosis and you're saying intraconal lesion on CT scan.
There was a mass superiorly also, ma'am. I think that may press the globe downwards.
Okay, okay. So now you what kind of etiology do you expect? No? Now, whenever you think of etiology in orbit, it is VEIN, vein, right? Is it vascular? Is it endocrine? Is it inflammatory, or it is neoplastic? Correct. Now, is it vascular? What are the signs of vascular lesions in the orbit? Can it be vascular for her?
It can be vascular.
Yes. What kind of vascular lesion can it be? When you look at the scan, you have an isolated mass lesion intraorbital, and you're saying it is retrobulbar. What will you think of in this age?
Cavernous hemangioma.
So that is one possibility. Any other vascular lesion you can think of in this age? No. Okay. So vascular is over. Inflammatory, you think it is like that? You think it is
It is not pain. Oh, acute presentation. It was a chronic presentation.
no pain. It's important symptom. There is no pain. Okay. And the eye is not congested. There is no sign of inflammation. So let us not think of inflammatory now. Okay. The last one is neoplastic. So in neoplastic, you think of benign and malignant lesions. Okay. So what are the neoplastic lesions you can find in that location?
Neural tumors, ma'am.
Yes. Okay.
Like,
Neural. And what else? Now, I want you to open that scan picture and show me once, and I will ask you a few questions. Quickly show me the scan. So
We
in a,
have time, Dr. Preeti. You can discuss in detail about imaging. I'm a big fan of your imaging classes, so I really wanted you to explain in detail about imaging.
so this is, yes. So when you have an image in front, how will you describe this? Quickly tell me in the exam, if they put a film on in front of you, how do you describe this?
First, what type of imaging it is? Whether it is CT, what view we can see axial and coronal view.
Excellent, excellent. What else?
What part CT orbit? CT orbit.
You'll say window also. So you will say it is CT orbit. You're right. And then you said it is coronal and axial view. Perfect. And then you said these are mostly bone windows, right?
Yes, ma'am.
Correct. So if it is a tumor that you're thinking, then you must ask the examiner that in this particular scan, you can only comment on the bony part of the scan, right? Not too much on the soft tissue.
Yes,
Okay. So don't try to comment on a raw window. Okay. Now this is the bony window. So what you can comment maximum is that, okay, there is a tumor, but too much characteristics of the tumor you can't tell on this window. But what you can say is there is no hyperostosis, correct? There is no bony change. But I can see some bony change in the coronals. Show me the other coronals. There was another film you had shown, no, previously. I want to see that one.
This is the only film I've attached.
Or something else. Come down, come down. Yeah, yeah. Come down. Yes, yes, yes.
Yes, ma'am.
So now you see, can you see my cursor? No, no. Okay. So you see the row which is above the last row. Second last row, will you see? Now in that, you see the bony orbit.
Yes, ma'am.
You just follow, trace the entire bone. What do you see in the bone?
There is a discontinuity.
Yes.
And,
so that you have missed. Okay.
yes, ma'am.
There is a discontinuity. But what kind of discontinuity is there in the bone? So you have two types of bone problems, no? When there is a tumor. If there is a malignancy, what happens to the bone?
If it's a malignancy, there will be bony destruction, ma'am. In benign, long-standing conditions, there can be bone remodeling, ma'am.
What do you think that has happened here?
Here, there is a bony destruction, ma'am.
See, destruction will be irregular bone. Okay, it's
Yes, ma'am.
destroying it. But here you can see a regular bone. It's thinned out in one place and just it's the edges are very rounded.
Yes, ma'am.
Okay, it's not like a erosion. Okay, so I
Yes,
would think that this is more like a benign thing which has caused bony changes. Okay, sometimes the
Yes.
remodeling is so much that the bone gets very much thinned out. Okay,
Yes, ma'am.
and
Yes.
you can also see that the nerve is below this lesion. Can you see that?
Yes, ma'am.
So the nerve is separately seen. Do you agree? In all
Yes,
these
ma'am.
images, you'll see nerve is separate. So it is not a neural tumor.
Yes, ma'am.
Okay. So now there is some lesion which is intraconal, which is above the optic nerve, in between the optic nerve and the superior rectus. And on one side, it is also pressing on the bone for a long time. And it is a middle-aged lady. What can you think of?
Nerve sheath,
Nerve sheath. So which other nerve lies there other than the optic nerve?
superior orbit.
What other nerves are
Schwa-
there? Yes. Can you repeat that?
Schwano, ma'am.
Yes, it can be, right?
Yes, ma'am.
Yeah. So it can be one of the DDs. Now, what are the other features of schwannoma that you will think? Is it a solid lesion? What kind of a tumor is it?
Solid, firm,
Yes. So
well
now go
circumscribed.
back on the axial scan.
Yes, ma'am.
Axial, where the entire lesion was seen well. Yeah. So you can see that it is not completely homogeneous. Can you come that last row that you can see? In that, if you
Yes.
see the third and the fourth images, is it very homogeneous intensity? Don't move anything now because then I can't explain. The last row, yeah.
Okay.
The last row, if you see the center two images.
Sush, don't move it. Keep it stationary.
Yeah.
Yes, ma'am.
Last row, if you see the center two images, what do you see on that? Is it a same color? Is it the same intensity all throughout? Hey, you changed it. So it was
Sorry,
having
ma'am.
kind of inconsistent intensity, right? I think it is cystic. Okay.
Yes, ma'am.
So you have a cystic lesion and it is above the optic nerve and it
Yes,
is
ma'am.
this shape. It can also be a schwannoma, like you very rightly said. So don't have
Yes,
a very fixed mind that because there is optic atrophy and because it is a fusiform, it has to be a glioma or a meningioma. You don't have features of meningioma here. There is no tram track sign here. But tram track sign is seen on contrast. You need to give contrast. And then you will see the optic nerve separate from the enhancing lesion on the side, right? So you need to have a contrast scan to know, and obviously the lesion has to involve the optic nerve. You won't have the optic nerve separately lying there like that.
Yes, ma'am.
Correct? So schwannoma is one of the diagnoses. But the main thing is your examination. So when the eye is proptosed like this, how do you exactly measure how much proptosis is there? In this particular lady, how will you know? Like you told me on Hertels, it is 35 and 30. So how did you note that on Hertels? What does Hertels tell you?
It was in two-ruler method, ma'am. What I did was two-ruler method.
Okay. So how did you do the two-ruler?
From the bridge of the nose, the corneal reflex will be measured in both the sides horizontally, ma'am.
Okay. So that tells you the displacement in which direction?
It was outward displacement.
Okay. And then?
And vertically, when we measured, it showed downward displacement in the left eye, ma'am.
From which structure do you measure the corneal reflex? What is your landmark? Like here you said the nose. For vertical, what part do you take?
From the superior orbital margin.
Okay. So now you see practically if the eyeball is coming out, okay,
Yes, ma'am.
then you will not be able to touch the rim very comfortably. Okay,
Yes,
so
ma'am.
it's only a rough estimate.
Yes, ma'am.
Okay. And vertical, horizontal, then how do you do the axial? All the three planes you must comment on.
Axial from the lateral orbital margin to the corneal apex, ma'am.
Correct, correct. So those are the three measurements that Paka you should know. Okay. Then what else
Yes,
do
ma'am.
you do in case of a mass lesion? How do you examine? Palpation, how do you do in an orbit?
The orbital margins have to be palpated. Insunation, whether it
Suppose-
is possible.
1 minute, one. So when you are palpating the orbital margin, now you want to palpate inferior orbital margin. Okay. Where will you ask the patient to look?
Down
Down. Why do you want him to look down?
to relax the orbital septum.
Perfect. Excellent. Okay. So why do you want to examine the rim in these kind of cases? What will you?
There is any bony erosion or destruction.
Okay. What else? Usually anterior rim destruction you don't see, no?
Yes.
What do you actually look for in these kind of cases? Yes? Sushmita, are you there?
Yes, ma'am. I'm there.
So you will see if you can feel the mass, right?
Yes, ma'am.
Yeah. So you will feel the mass in some of these cases. So
Yes.
if you are feeling a mass, what is it further that you want to know on palpation?
The consistency.
Okay. How do you know consistency on palpation?
Whether it is soft or firm
Okay.
or hard.
Okay. What else?
Margins.
Okay.
Whether it is reducible or compressible.
Yes. So what does reducible and compressible tell you?
Reducible, when we are pressing it, it does not come back, ma'am. On compressibility, it comes back.
Okay.
Vascular lesions are mostly compressible.
Okay. What else? Once you have felt the rim, you felt for the mass, and what else you will do then in the examination, in the palpation?
Resistant retropulsion, ma'am.
Okay. How do you do that?
The patient, we should ask the patient to close the eyes, and then with the thumb, we have to press and look for any resistance to retropulsion, ma'am.
Okay. And if you have a resistance, that means what?
It's an retrobulbar mass present, ma'am.
Okay, but then even if you have a very soft vascular lesion, you may not have too much of resistance. So it means that it is more of a solid lesion.
Yes.
Okay. Now, coming back to the radiology, which Dr. Sharmila wanted me to discuss more. Now, this is a CT scan. Now, for tumors, which is a better modality of imaging?
For soft tissue tumors, MRI is
Better, yes.
better.
So even I prefer an MRI if I suspect a tumor. But if I'm suspecting thyroid or if I'm doing a trauma where I need the bony anatomy, then I ask for a CT scan. So normally what thickness slices they give you on a CT scan?
Normal 1 to 10 mm cuts are given in CT scan, ma'am.
Yeah.
We specifically ask for 2 mm cuts in case of orbit.
Okay. So now for trauma, everything, when you want to reconstruct and all that, less than 1 millimeter cuts we are asking. Okay.
Yes, ma'am.
You can say in the exam 1 to 2 millimeter cuts is what you want. Okay.
Okay.
But if you're suspecting an optic nerve pathology, then you need the optic nerve cuts
Yes, ma'am.
also. Okay. And MRI is
Okay.
preferable. Now, so if you, whether you will ask contrast or no contrast, when do you ask for contrast?
When we suspect suspect any vascular lesions, we can ask for contrast, ma'am. Normally, the orbital fat itself will provide a better a contrast case of CT orbit, ma'am. So when there's a vascular lesion, when there's a vascular lesion or any internal extension or cases, we can ask for contrast, ma'am.
Yes. So most of the time when you suspect a tumor, you'll ask for contrast. Okay. In trauma, you don't need contrast.
Yes, ma'am.
Just have a trauma orbital fracture, you don't ask for
ma'am.
contrast. For tumors, you will ask for contrast. Understand? So that's why when you were talking about tram track, if you're not talking about contrast, I will not give you marks. Okay, you should understand what is the tram track sign.
Yes, ma'am.
Now, if you're doing an MRI, what kind of specifications that you will ask the radiologist? Will you ask just MRI or you will ask specific MRIs for specific lesions?
For vascular lesions, MRA, MRV.
Okay. What else? Hello? Sushmita.
Yes, ma'am. Ma'am.
Else? Contrast again, when do you ask, when you don't ask?
Contrast we'll ask.
Hmm?
We'll ask for contrast, ma'am.
For which kind of lesions?
Vascular lesions, ma'am.
Vascular lesions. Okay. What else? Any other particular sequence that we ask for in MRI? In orbital lesion.
Diffusion weighted.
Exactly. So why do we ask for diffusion weighted imaging? In which kind of lesions they are very useful?
In case if we want to know about the optic nerve infarction, we can ask for diffusion weighted.
Yeah, you're almost like a fellow. What else?
Ma'am, in the interest of time, can we
Yes.
Can we just wind up with the concluding remarks?
So diffusion weighted imaging specifically for lacrimal gland lesions, you will ask. Okay, that distinguishes a neoplastic lesion from an inflammatory lesion. So then only you will decide whether you want to do an incision biopsy in cases of inflammatory lesion or excision biopsy in cases of neoplastic, like a benign lesion. Okay.
Yes.
So diffusion weighted imaging is important in these cases. So in cases of proptosis, always do the Navzigas like you said already. Always look for warmth and tenderness before you start palpating. Okay, because once you start palpating, that area temperature will increase. So warmth, tenderness is very, very important. And of course, just go systematically when you're describing the imaging. You don't have to come to a diagnosis. But see, you have missed the bony erosion or the bony remodeling. You have missed the cystic appearance. And the lesion is above the optic nerve. It is not arising from the optic nerve. Okay?
Yes, ma'am. Yes,
Okay. Thank you.
Preeti ma'am, can you also conclude saying the few words about the management for this case? How would you manage further?
Yeah, so it all depends on the radiology. If it is a schwannoma, like I am thinking it is going to be, then you just need a complete excision. So in that case, you will do a orbitotomy. Now, orbitotomy here, since it's a very large lesion, and for your PG examination, best orbitotomy here would be a lateral orbitotomy because you need more access. Okay, so you will have to remove this bone and you will have a nice wide exposure, and then you will remove this lesion in toto. And if you just want a biopsy, suppose you think of some other lesion like a cavernous. So in cavernous hemangiomas, the lesion is very soft. It can mold and come out. In those cases, you don't have to remove the bone. You can just remove the lesion because only 3/4 of the lesion you need to really dissect, and then you apply a cryoprobe and the lesion comes out like a cavernous. Okay. Now, if it is meningioma, what is the mode of treatment? In meningiomas, you can do, now since the patient has no vision in that eye, you can do a globe sparing excision. Okay. Provided the lesion is progressing. Sometimes the lesion does not progress. You can observe every 3 months, you see if it is increasing or not. If it is not increasing, you can leave it as it is. But it is causing proptosis, causing all the symptoms to the patient. So for that, you will do an optic nerve sparing excision. But if the patient has some vision and you want to retain the vision for some time, then you can try a chemotherapy. Nowadays, chemotherapy is indicated for glioma as well as meningioma just to stabilize the lesion. Many of these patients, the lesion does not progress. It just stays that way so that you can, allow the vision to slowly deteriorate instead of you just interfering and removing the optic nerve along with the lesion. Okay.
Yes.
And also stereotactic radiotherapy is available for meningiomas. Although
Yes,
these modalities do not cause a complete cure for the problem, it just prevents a progression. And so you can wait and buy some more time with vision.
Yes.
But if you don't have a vision, you need a excision. So you must know all the orbital approaches, with what incision we approach, which area we approach, and what are the types of orbitotomies for the exam.
Yes,
Okay.
ma'am. Yes, ma'am.
Thank you very much, Dr. Sushmita, for the wonderful presentation. Thank you, Vijay sir, for the wonderful discussion, and Preeti ma'am for the amazing points and take-home messages for the PGs.
Sushmita, if you want to do fellowship, you come to me, okay?
Sure, ma'am.
Sushmita's day is made today. So we move on to the next presentation. Dr. Suganya from Madurai Medical College will be presenting a case of uveitis, and we have 3 examiners. Professor Hemanandini Madam from RAOGOH, Professor Periyanagi Madam from Madurai Medical College, and Dr. Padmapriya from Madurai Medical College. Over to you, Dr. Suganya. Suganya, are you there?
Yes, ma'am. Good evening, ma'am.
Good evening, Suganya. Yeah, you can start sharing your screen.
Okay. Shall I start, ma'am?
Yeah, please start.
Okay. Good evening, ma'am. 37 years old female, Mrs. Mrs. Valadmati, presented with complaints of defective vision in right eye and intermittent headache for the past 3 months. Patient came with complaints of defective vision in the right eye and intermittent headache for the past 3 months, which was gradual in onset, progressive in nature. No history of redness, no history of photophobia, no history of watering, no history of colored halos or floaters, no history of ocular trauma, no history of fever, cough, loss of weight, no history of joint pain, no history of ringing in ears and hearing loss, no history of nausea or vomiting, no history of any skin lesions. Past history, patient had a history of sudden onset of right eye pain, a redness associated with the severe headache, followed by right eye defective vision before 3 years. Then she was investigated for the same and diagnosed as a case of.
Dr. Suganya, change your slides.
Ma'am?
Are you changing the slides? I'm not able to see them.
Yes. Yeah, your slide
Yes,
is not moving, ma'am.
Change.
Go to slideshow. Manjula ma'am, do you have the presentation?
You can go to slideshow, Suganya.
Slideshow.
It's not moving, huh? Or just click on the slide. Just click on the next slide if the slideshow is not working.
How is it?
Yeah.
Moving.
Yeah.
Okay. Past
You have to
history.
change the slide by yourself, right? You keep on presenting. Just change the slide whenever you're going to the next.
Keep on clicking on the slide.
Okay, ma'am. past history, patient had a history of sudden onset of right eye pain, redness associated with severe headache followed by right eye defective vision before 3 years. Then she was investigated for the same, and the patient was diagnosed as a case of sarcoidosis. After blood and radiological investigation, patient was started on systemic and ocular steroids. Also, she referred to rheumatologist for the same, and after 1 year, she was also prescribed immunosuppressive therapy. Now patient is on tablet prednisolone 10 mg OD and tablet methotrexate 10 mg weekly. After 1 year, the patient was underwent cataract surgery in the right eye. Then she lost follow-up. After 6 months, patient came with complaint of pain in right eye and found that her IOP was increased and diagnosed as a case of angle-closure glaucoma, and YAG PA was done in right eye. Now patient is on dorzolamide and timolol eye drops in both eye, BD for the past 1.5 years. Patient is not a known case of diabetes mellitus, hypertension, TB, asthma, or coronary artery disease, and thyroid. Coming to the personal history, patient takes mixed diet, normal bowel and bladder habits, regular 28 days menstrual cycle with no history of contact with pet animals. Family history, no history of similar illness in family members, no history of TB, diabetes, other autoimmune disorders in the family members. In general examination, patient is conscious, oriented, moderately built, lymphadenopathy at present. Pulse rate was 78 per minute, and BP was 120 by 80 millimeter mercury. CVS S1, S2 heard, and RS, normal vascular blood sounds was heard, and parabdomen soft, non-tender. CNS, no focal neurological deficit was seen. Now, coming to ocular examination, head posture was normal, no facial asymmetry. Patient's uncorrected visual acuity in right eye is 5/60 with nil improvement, and left eye 6/12. Best corrected visual acuity in right eye was 5/16 nil improvement, and in left eye with 6/12 with 0.5 dioptric sphere and 0.5 dioptric cylinder at 180 degree is 169 partial. Now, oblique examination. Right conjunctival, cornea clear, anterior chamber moderate depth, iris color and pattern normal with atrophic patches, and PA was present in 7 o'clock position. Pupil 5 mm pharmacologically dilated, and pupil was not reacting to both the direct and indirect eye reflex, and PCI lens was PCIOL, and eyepiece over the anterior surface of IOL was present. EOM was full. In left eye, lids normal, conjunctiva normal, cornea clear, anterior chamber moderate depth, iris color and pattern normal with atrophic patches seen. Pupils 3 mm round, regular, and sluggishly reacting to both direct and indirect eye reflex. Lens was present with immature cataract, and EOM was full. This is the anterior segment photograph. Slit lamp examination. A slit lamp on right eye, lids normal, conjunctiva normal, cornea, iris pigments over the back of the cornea, and few keratic precipitates were present. And the anterior chamber 1/4 to half of peripheral corneal thickness, no flare and no cells present. And iris color pattern normal, atrophic patches were present, and PA at 9 o'clock position, which is patent PA. And pupil 5 mm pharmacologically dilated pupil, not reacting to light. Lens PCIOL, iris pigments over the anterior surface of the lens was seen. In left eye, lids normal, conjunctiva normal, cornea clear, anterior chamber is equal to half of the peripheral corneal thickness. No flare and no cells were present. Iris color pattern normal with atrophic patches present in the iris, and pupil 3 mm round, sluggishly reacting to light. Lens grade 2 nuclear sclerosis was present with no PX of lens. IOP measurement by Goldman applanation tonometry at 10:30 AM in sitting position. In right eye was 14 millimeter mercury, and left eye was 16 millimeter mercury, and patient is on anti-glaucoma medication. Both eye color vision normal. Gonioscopy by Schafer's grading. Right eye, the superior quadrant, the grading was 1, and inferior nasal and temporal, and the grading was 2, with the peripheral anterior synechiae was present in superior and temporal quadrant. In left eye, superior quadrant was graded as 1, and nasal temporal and inferior was graded as 2, with peripheral anterior synechiae present in nasal quadrant. This is the gonioscopic finding, ma'am. And coming to dilated fundus examination and right eye, media was hazy due to vitreitis changes, and the disc was hazily seen with peripapillary atrophy. Cup disc ratio was 0.4:1 with vessels dilated tortuous vessels. The arteriovenous ratio was 2:4, and the macula on F4 was could not be made out due to hazy view. And left eye view mildly hazy with disc was size shape color normal with peripapillary atrophy, and the cup disc ratio was 0.4:1 with the dilated tortuous vessels. The AV ratio was 2:4, and the macula normal and FR was dull. This is the fundus picture of right eye, ma'am. This left eye. Coming to case summary, 37 years old female patient presented with complaints of defective vision in the right eye for the past 3 years, since last 3 months. Patient is a known case of sarcoidosis for the past 3 years and on treatment of tablet prednisolone and tablet methotrexate. Patient is also known case of glaucoma for the past 1.5 years and on dorsolamin temporal eye drops in both eyes. On examination, best corrected visual acuity in right eye 5/60 and left eye was 6/12, improving to 6/9, and right eye cornea showed a few keratic precipitates on endothelium. The IOP by Goldman applanation tonometer in right eye was 14 and left eye was 16 millimeter mercury. The gonioscopy in both eye closed angle with the tin-shaped peripheral anterior synechiae. On fundus examination, right eye showed vitreitis and with right eye PCA1, left eye grade 2 nuclear sclerosis. The diagnosis, provisional diagnosis was both eye pan-uveitis with the secondary angle closure glaucoma, probably due to presumed ocular sarcoidosis.
Thank you, Dr. Suganya. Can you have your video on? Over to the examiners. Professor Hemanandani, Madam Professor.
Sharmila, am I audible?
Yes, ma'am. Yes, ma'am. Good evening, ma'am. You can start.
Yeah, good evening. Hi. You said pan-uveitis, no, ma?
Yes, ma'am.
Can you just justify why your diagnosis, why you are saying pan-uveitis?
Patient is having anterior uveitic feature, which feature, ma'am, like keratic precipitates, ma'am, and vitreitis was present, ma'am. So she can have.
But what do you mean by pan-uveitis, ma?
Involvement of anterior, intermediate, and posterior.
Suganya, can you have your video on, please?
Hello, ma'am.
Yeah. Like, so you have pan-uveitis involvement of all the 3 layers, is it? So how do you justify that? You said anterior uveitis in the form of keratic precipitates. And this vitreitis you said. And was there any posterior uveitis?
Ma'am, at the time of presentation, we were finded very vascular sheathing, ma'am. But in this fundus view, it was not clearly seen.
Okay. This perivenous sheathing you are saying, no? What does it indicate? If there is a sheathing along the vessels, what will be your, what does it indicate? It actually indicates the involvement of the vessels. Am I right?
Vessels. Yes, ma'am.
More of a retinal vasculitis.
Yes, ma'am.
So these perivenous things you get only in sarcoid vasculitis, no? So
yes,
is retinal vasculitis included in pan-uveitis according to Sun classification? You know you answer, otherwise. So Sun classification, what is Sun classification, ma?
Standardization of uveitis nomenclature.
Retinal vasculitis is not included as a pan-uveitis. So this perivenous everything may be present, but it is not a posterior, it's a vasculitis. Okay. So sarcoid posterior uveitis, what features you should have?
Choroidal infiltrations and
you can have choroidal infiltrates. Can you describe how they will appear?
They will appear as whitish yellow lesions with obscuration of vessels of the choroid, ma'am.
So you can get these infiltrates, or you can also get granulomas.
Granulomas.
Did you come across any such lesions in this patient? But your media was due to vitritis,
yes.
you said. But
Yes,
did you ask the patient all these complaints, any new fresh complaints started after her surgery? Because she doesn't seem to have a very good vision in that eye. And did you ask about the intraoperative and postoperative period?
Yes, ma'am. I have asked, ma'am. After cataract surgery, her vision was improved, ma'am. And before 3 months only, her vision was dropped, ma'am.
So did she have any fever or reactivation of her systemic disease in these 3 months?
She had only defective vision in worsening of her defective vision in 3 months, ma'am, and having headache, ma'am.
What I would suggest is this patient came to you with pain, redness, and defective vision. No pain, no redness, just defective vision. Am I right?
Yes, ma'am.
So this patient has come to you with the unilateral defective vision.
Yes, ma'am.
Am I right? So your examination findings, you could see a keratic precipitate.
Yes, ma'am.
You never, the flare was not there?
No, no flare.
Generally, in any uveitis, the flare usually persists because it is due to the breakdown of the blood aqueous barrier. And even if the flare persists, it does not indicate activity. So the flare should have been there. Probably you have missed. Understand? So any type of uveitis, flare will persist. Okay. So second point, so this patient has a keratic. Was there any posterior synechiae?
Yes, ma'am. No, ma'am. No posterior synechiae, ma'am. Only peripheral anterior synechiae was there, ma'am.
And you also mentioned tent-like peripheral anterior synechiae. Because you know a diagnosis, because you knew that she is a known case of sarcoidosis, that made you look for a tent-shaped PAS, or was it actually present? Because you say she is also a case of glaucoma, her AC is shallow, she has YAC PI, she would have had subacute angle closure attacks. So that also would have caused a peripheral anterior synechiae. So which do you think? It's because of the sarcoid is going to cause this tent-shaped pass, or your angle closure attack? Actually, this case is somewhat vague. It's not so very much suitable for an exam point of view, but still we will discuss. So you should always go with the open mind. You are always going in the line of sarcoidosis because you know that patient is a known case of sarcoidosis. You are thinking in lines of sarcoid anterior uveitis. Am I right? So you should never do that. You should always see the case with an open mind. It could be something else also. If you just look into sarcoidosis, you may miss so many other causes which could have been the reason for the uveitis. So this patient also underwent a cataract surgery. Any uveitis, when patient undergoes cataract surgery, there will always be a reactivation. Am I right? Okay. So this vitritis also, we cannot say that it is purely due to this sarcoid. Did you get a systemic opinion from her treating physician regarding her sarcoid status? You said already she is on methotrexate and she is also on oral prednisolone. Am I right? So when there was a vitritis, did you get a opinion from your treating physician whether they need to increase the dosage of immunosuppressants or steroids? Did you do that?
No,
Tell me yes or no.
Patient was regularly when follow up.
So she was on follow-up and they knew that, and they also didn't increase the dosage. So that indicates that there was no reactive or increase in the severity of the systemic disease also. So see, this case is somewhat confusing case you are presenting actually. So now we will leave sarcoidosis. Okay. So generally, what type of which uveitis is very common in sarcoidosis? We'll go to the
Anterior
theory
uveitis.
part. So anterior uveitis is the most commonest presentation of a sarcoid. And how about the anterior uveitis? Is it unilateral or bilateral, or what is it? Granulomatous or non-granulomatous?
Bilateral granulomatous anterior uveitis is common in sarcoidosis.
Usually it's a bilateral granulomatous, and it's chronic or acute?
It's chronic, ma'am. Acute also
can
it can
happen.
present.
Yeah.
Yes, ma'am.
So chronic usually occurs in when there is a pulmonary disease or older patients, you get a chronic granulomatous uveitis. What about the acute one? It can also occur when sarcoidosis presents acutely. The patient can also present with acute anterior uveitis. It's more common in much younger patients. So what is the age of your patient?
37 years.
37
years. Yes,
okay. And what about the other eye? Other eye is perfectly all right, no? Excepting for the angle closure part. Otherwise, he doesn't have any uveal involvement at all. So still you think only because of sarcoidosis it is causing this, because there is nothing to call it as granulomatous uveitis, because you said keratic precipitates. Do you want to define the keratic precipitates? They are just small or medium size or old or mutton fat. Like what type of keratic precipitates you saw?
They are medium sized, ma'am. Now, medium sized.
So they look like what occurs in a granulomatous uveitis? Do you think?
Mutton fat
I couldn't see anything in your photograph. Okay, leave the sarcoidosis point. Leave the sarcoidosis point. Okay, this patient has come to you with a patient is coming to you with redness, then no redness, only defective vision. She's coming. Incidentally, you know she's a known case of sarcoid. And what your clinical findings? You have only keratic precipitates, and of course she has underwent cataract surgery and she has a vitritis. Now, you want to revise your diagnosis? Just leave sarcoidosis aside. Okay? What else can you think can cause this picture?
Can be a post-operative endophthalmitis.
Why endophthalmitis?
Post-operative
Why endophthalmitis? You said vitritis, no?
Post-operative uveitis.
So patient can also have vitritis, no? It's very common because you do not know anything about the surgical intraoperative complications or anything. You didn't know. You didn't mention. You never said uneven full or anything like that. Or it could be an uveitis due to any other cause, which has got, there is a reactivation of uveitis following the surgery. Anything could have been happened, no? In fact, you should also rule out tuberculosis. Because patient is a known case of sarcoidosis, you cannot take that for granted. Okay? Because this cannot be due to a sarcoid reactivation, because already patient is on methotrexate and prednisone. Okay, we will now this patient, actually the diagnosis is not somewhat, because you knew that it was a sarcoid case, and so you are going into that lines. So let me ask some of the other findings in sarcoid. Since you said tent-shaped peripheral anterior synechiae, no? So that is commonly occurs in sarcoid. So what else you can get in the angle in sarcoidosis? Anything else you can get? Any nodules you can get in the angle?
Nodules.
What are they called? What are the nodules in the angle in sarcoidosis called? You know your answer, otherwise I can tell you. Of course, in the exam, you should answer. So those are called Berlin's nodules. You've heard of it?
Yes, ma'am.
Yeah. And then what other features of sarcoid? How all a sarcoid? What are the ocular manifestations of sarcoid?
The conjunctival nodules can appear, ma'am.
Okay, they have a specific name. Conjunctival nodules, they have a specific name, no? You know that? These nodules, they look like small grains, no? They are called millet seed nodules. Okay, then come next. What else you can get?
Candle wax dripping. Candle wax
You are
dripping.
jumping,
like,
you are jumping. When the exam, if they ask you, you have to go either from anterior to posterior or posterior to anterior. Okay. So from conjunctiva, you have jumped to vasculitis. Okay. So in iris, can you get nodules, granulomas?
Nodule, yes, ma'am. Yes, ma'am.
Yes, okay.
Copies and Lusaka nodules we can have, ma'am.
Okay, this
In iris.
angle you have told already. And posterior uveitis, intermediate uveitis, what can you get? What specifically you can see? In sarcoidosis.
Granulomas in
Yeah, so they usually form a string of pearl appearance. Snowball opacity is forming a string of pearl in an intermediate uveitis. Posterior uveitis. Then vasculitis can you be more specific? What type of vasculitis does the sarcoid cause? Obliterative or non-obliterative? Occlusive or non-occlusive?
occlusive vasculitis.
Usually tuberculosis, Behçet's and all will cause occlusive vasculitis, whereas sarcoid will cause a non-obliterative vasculitis, and also the vasculitis will be segmental. What do you mean by segmental? In the involvement of vessels, veins or arteries will be involved in sarcoidosis, preferably.
Veins, preferably veins.
So it's mainly a non-occlusive periphlebitis and it is segmental. So in between you will have normal vessels and it will be segmental. In contrast to tuberculosis, what do you call that sheathing in tuberculosis? It's called pipe stem sheathing because the entire vessel it will be cuffed. Okay. So I don't think this is a case of sarcoidosis because it was a like you knew the systemic known case, no? So you're going, never do that. You have to examine the case methodically. Since this patient must be having some chronic uveitis because there is no pain or redness. Only thing you have noticed is the keratic precipitates. So you have to work up this patient some more and find out other possible etiologies. And you said YAC-PI was done, no, this patient. And with the anti-glaucoma medications, her intraocular pressure is under control. What about the other?
Other eye also under control only.
Okay. How old is your patient?
37 years.
37. Can you think of any other possibility unilateral? Supposing this patient has pain and redness also. This patient, young patient, pain and redness also present. And there is a severe reaction in the anterior chamber also. What will be your possibility? Because this case, you leave it aside. This same patient presenting with pain, redness, 37-year-old. Okay. What possibility will you think of? Especially a male patient. Anything also has a low backache.
Ankylosing spondylitis.
You should think of ankylosing. Though it is more common in males, there's nothing wrong in. It can also occur in female patients. This is not, of course, this patient is not ankylosing spondylitis. This patient does not have any findings to discuss uveitis other than keratic precipitates, and then you have a vitritis. We really don't know what has happened to the patient. Okay, there is no continuity. Suddenly patient is undergoing cataract surgery and suddenly the patient is developing diagnosed as angle closure glaucoma. See, multiple symptoms and signs are there and which are not correlating well. Okay, so probably the patient has not come for follow properly and you have not seen the patient on the first episode. That must be the reason, I think. So tell me some other causes for acute anterior uveitis. Can you tell me some other causes?
Tuberculosis.
Okay. Anything else? Tuberculosis usually does not cause acute, no? It only causes chronic. Dr. Perinaigi wants to ask some question. You answer.
Yeah, you've done iridotomy, Lama. In uveitis cases,
Yes,
will you do only one iridotomy or do multiple iridotomies? What is advisable in a case of uveitis? Will it not close immediately whenever there is an inflammation if you do one iridotomy?
no, multiple
Yes or no?
iridotomies.
Yeah,
No,
at
ma'am.
least 2 or 3 iridotomies have to be done in uvea cases. Okay, that is one point. Then how does an anatomical classification helps you to derive at the diagnosis, ma? Whenever you see a case of uveitis, is it mandatory to classify anatomically whether it is anterior, intermediate or posterior? Yes or no?
Yes, ma'am.
Yes. How does it help? If it is anterior uveitis, there are some differential diagnosis. If it is intermediate uveitis, you have 1, 2, 3, the same way posterior uveitis. So can you tell me 1 or 2 differential diagnoses if there is an acute anterior uveitis, as madam asked now? Acute anterior uveitis with severe
viral
pain.
infections.
Patient
Viral
may be
infection.
present even with perception of light in a young male.
You said no, ma. Acute anterior uveitis. Just
very painful.
Yes.
B27 associated.
Ankylosing. Then what else?
Yeah. If there is a fibrin in the anterior chamber, it is confirmatory that you're dealing with a case of HLA B27. No other type of uveitis, tuberculosis or sarcoidosis will present with fibrin. Okay? So you seeing at the patient, you need not do any other investigation. You can directly document a HLA B27 associated and ask for a rheumatology opinion. Okay? So this patient is not going to have much of cells in the vitreous or posterior segment involvement. This is purely, so anatomically localizing helps you to derive at the diagnosis. Now, your case, I think you have to revise the diagnosis as intermediate uveitis. Can you accept?
Yes, ma'am.
Your case is an bilateral intermediate uveitis. If you derive as intermediate uveitis, what will be the differential diagnosis? 1, 2, and 3. Suganya, just speak whatever you know.
It may be.
Yeah.
It may be due to tuberculosis.
For intermediate uveitis.
It may be due to tuberculosis or sarcoidosis.
Whatever disease you see, you can say tuberculosis as first DD. Will never contradict. Head to foot, anything can be tuberculosis. At the same time, anterior, intermediate, or posterior uveitis, the first differential diagnosis can be in tuberculosis as far as we are in Asia. Okay? Accepted. What will be the second differential diagnosis if it is in bilateral intermediate uveitis? Because intermediate uveitis is always bilateral. Most of the time, 90%, it is bilateral. So your second differential diagnosis will be?
Due to sarcoidosis.
Yes, exactly. It can be sarcoidosis. Now revise your diagnosis and come to a conclusion. Whether it is a bilateral panuveitis or bilateral intermediate uveitis, and your first differential diagnosis is sarcoidosis. Yes?
Yes, ma'am.
If not, what could be the other differential? So sarcoidosis comes first now, and tuberculosis goes to the second place. Now, what will take the third place?
It is unilateral, means can
most of the time
toxoplasma.
Illamma. Intermediate toxoplasma is posterior uveitis. Why do you want to bring toxoplasma here? Anatomical classification helps you to derive at the differential diagnosis 1, 2, 3. Now, this is not your case is not a purely anterior uveitis. Accepted?
Yes, ma'am.
So,
yes, ma'am.
It cannot be any other disease, whichever, it cannot be Behçet, which is presenting with an hypopion. It is not HLA B27 associated. It is not other toxoplasma or anything. It is an intermediate. You told there are cells in the vitreous and both eyes. So it is a case of intermediate uveitis. And your first differential diagnosis will be If you're not
sarcoid
knowing the patient is a sarcoid, it can be tuberculosis, second is sarcoid, and third is multiple sclerosis.
multiple
But you
sclerosis.
Yes, it's a sarcoid. We will keep it that we are not knowing the diagnosis. We'll just classify. It is a case of intermediate uveitis. Your first DD is tuberculosis, second is sarcoidosis, and third is
Multiple sclerosis.
Sorry to interrupt. 1 second. Doctor, what is the vision in the other eye? You said 6.6 or 6.9, no? It was improving.
6.9, yes, ma'am. Yes, ma'am.
And
6.9, ma'am.
did you say that vitreous cells were there? Did you say there was an intermediate uveitis in the other eye?
Other eye, no, ma'am.
Then how
your
come
diagnosis
your
is
vision is
bilateral,
good? How come your vision is good, doctor? You said one eye, the media was very hazy due to vitritis. Am I right?
Yes, ma'am.
So the other eye, apart from cataract and the narrow angles, nothing else was there. Correct?
Yes, ma'am.
Initially, she presented
So now
with
you are dealing
both
with the
eyes,
case
madam.
of unilateral intermediate uveitis. Even that is very confusing. Like you have to, as she said, you have to revisit the diagnosis, doctor.
Illa, madam, the patient had bilateral initially, treated on methotrexate. Now the complication due to intermediate uveitis may be a cystoid macular edema patient.
Is that so, doctor? The patient came with bilateral complaints?
Yes, ma'am. Patient came with bilateral.
Bilateral complaints?
Yes, ma'am. At the time of presentation, patient came with bilateral complaints only, ma'am. Now she is.
The time of presentation is before 3 months or before 3 years?
Before 3 years, ma'am.
Be clear in that. Be clear in that.
Yes.
You're not conveying your point. So
That's
at the time of first initial examination, she had bilateral, right? And
Yes, ma'am.
did she have any posterior segment findings during that time?
Ma'am, during that time, she have periblephitis in both eyes, ma'am.
So right now, the involvement is
in both eyes.
At present,
Yes,
she had complaints only in one eye, right?
Yes, ma'am. At present, she is having in one eye.
Initially, bilateral candleback strippings were there initially, is it?
Yes, ma'am.
Okay, why do you say it is presumed? Is it confirmed sarcoidosis or presumed or probable sarcoidosis? You've mentioned as this. What do you mean by that? What are the findings to say it is presumed?
Ma'am, the biopsy was not taken, ma'am. Any biopsy was not taken, ma'am.
Okay.
Yes, ma'am. Only in X-ray, patient had bilateral hilar lymphadenopathy, ma'am. And then the signs of uveitis. With the signs of uveitis, we have concluded as presumed, ma'am.
Did they do any biopsy, doctor, for diagnosing
no, ma'am.
Lung biopsy, anything was taken? Any tissue diagnosis?
No, ma'am. They didn't take any biopsy.
So the treating physician, how come they came to a conclusion of sarcoidosis without any tissue diagnosis? Because hilar lymphadenopathy can occur in tuberculosis also.
With the elevated serum AC level was there, ma'am, and with the hypercalcemia was there in her report, ma'am.
So they came to a diagnosis of sarcoidosis.
Sarcoidosis, probably.
Okay. Now, can you highlight?
Yes, ma'am.
No, continue.
Sarcoidosis, ma. Do you see more number of anterior uveitis or more they present with intermediate uveitis, or they present more with posterior uveitis, which is common in sarcoidosis? They may sometimes present with mild iritis, which we will miss in sarcoidosis. Mostly bilaterally, they will not present with mut and fed. That is not the commonest presentation. Now, this posterior synechiae, cataract, all this may be because of the intermediate uveitis, which will produce the posterior synechiae and secondary angle closure. Do you accept? What, Suganya?
Okay.
So this could be a case, is a case of sarcoidosis presenting as intermediately. You said this is presumed ocular sarcoidosis. So to say presumed ocular tuberculosis, what are the investigations that are necessary? Now, madam said, no, this may not be sarcoidosis if it is tuberculosis. Your points in favor of tuberculosis.
Montauk's test should be
tuberculosis, ma?
Montauk's test, ma'am.
Yes. No, clinical examination, how will you say? It's more likely to be a tuberculous etiology. Leave alone this patient. This patient is a pseudophakic eye. Okay. Supposing a patient with phakic eye, he has a posterior synechiae, and looking at the posterior synechiae, you can decide that you are going in terms of tuberculosis. What is the difference? How does a tuberculous posterior synechiae appear? Other words, a granulomatous posterior synechiae, how does it differ from a non-granulomatous posterior synechiae? What is the description given? Any idea, ma? You know? You know the answer? Yes or no? Don't know, it's okay. You can learn. So usually tuberculous posterior synechiae will be a broad-based posterior synechiae. Very typical of tuberculous anterior uveitis. Whereas in non-granulomatous, you will have filiform. That is, it will not be involving a larger area of the iris. So broad-based posterior synechiae is the important pathognomonic feature of tuberculous uveitis. Any other findings will tell you that it could be a tuberculosis. Anything else? What about the vasculitis I told you? How does a tuberculous vasculitis appear?
Some segmental.
You don't get segmental.
In other terms, madam is asking what all you'll see if it's a case of tuberculosis. What are the various ways in which a tuberculous posterior uveitis will present? What are the various lesions you can see in tuberculosis? This is not only vasculitis, right? What will be your findings? You said sarcoid granulomas, no? Can you get tuberculous granulomas?
Yes, for any granulomatous disease, you can get granulomas. So you need not hesitate. You can always say yes. You can get granulomas in any granulomatous diseases. Then can you get any abscess? Sharmila, time is running out.
Yes, sir.
Okay.
Yes, sir. Can you have some closing remarks, ma'am?
Yeah. Okay.
If suppose the same patient, 39-year-old lady with a headache, and she's having the same symptoms as your case, bilateral vitritis, and there is a disc edema. What will be your first differential diagnosis? Same as non-infective. Non-infective bilateral vitritis with a disc edema. Your first DD will be panuveitis. Can it be Walk-Koena Harada? Okay, right. So the anatomical classification will help you to derive the diagnosis.
See, doctor, whenever a patient with redness, pain, you just see the patient with an open mind. So if they have acute symptoms like pain, redness, defective vision, then you think more in terms of an anterior uveitis. When the floaters are the predominant finding in a white eye, you think of an intermediate uveitis. When the patient has defective vision and also a white eye, you should also think of the posterior uveitis. So the sun classification will tell you just to compare the presenting features and the anatomic localization of the uveitis. So you should always see the patient with an open mind and ask all the histories which you have rightly mentioned in your presentation. And always This point is very important. Presence of retinal vasculitis does not indicate a panuveitis. It is a separate entity. It can occur along with panuveitis. Okay. So the symptoms, everything you ask is very, very, history taking is very, very important in uveitis. Don't bother about the diagnosis. Okay, you did well. Very good. Keep it up.
It's a very good point from Hemanandini madam. Sometimes a skilled PG might be helping you. Some other person might be giving you some clues. So go by your own history and examination. And these are the take-home points that we want to drive in this webinar. Over to Dr. PP for concluding remarks on this case.
Very good discussion from Hemanandini ma'am. So she dealt very in detail about sarcoidosis. What I would like to tell all the postgraduates is, just by seeing the KPs, just by seeing the coagulum, just the hypopion. So you can come to a diagnosis, approximately 80% of the times you can come to diagnosis. So find KPs, what will be the distribution? If it's a herpetic keratitis, what will be the KPs like? If it's Fuchs, how will be the KPs? If it's a non-granulomatous, if the KPs is distributed diffusely above the horizontal meridian with iris atrophic patches, your first diagnosis will be a herpetic keratitis. If it's confined below and if it's a non-granulomatous, if it's a mutton fat, it is a granulomatous. If it's a diffuse stellate KPs, it is Fuchs. Like that, seeing the clinical finding in an uveitis case, mostly you can come to a conclusion, and all the investigations are only to confirm your diagnosis. So uveitis is, you require a large clinical acumen, a wide clinical acumen, and you should see many cases. Similarly, in a case of a posterior uveitis, by seeing the retina fundus, you can 100%, most of the time you can come to a conclusion. For example, in TB, most commonly you will be getting a granulomas, or you can get a miliary tuberculosis, multiple small lesions. And how will you differentiate a TB granuloma from a sarcoid granuloma? What are the immunological vasculitis? TB vasculitis, you cannot miss that. As madam said, it's an occlusive vasculitis with an extensive sheathing. It's a periphlebitis and it's occlusive. As madam mentioned, sarcoid is a segmental periphlebitis and it's non-occlusive. So the most commonest presentation in TB in our subcontinent is TB vasculitis, then will be a granuloma, then will be a serpiginous-like choroidectomy. It is not serpiginous. So next you should think whether it's the serpiginous means if there is infectious or non-infectious. Non-infectious immunological serpiginous choroiditis will be bilateral. It will be around the disc. If it's a TB, mostly it will be unilateral, mostly in the posterior pole. And there are a few other points to differentiate a serpiginous from a serpiginous-like choroiditis, which you get in tuberculosis. So likewise, by seeing the fundus, by seeing the anterior segment, you can come to a conclusion. So that clinical acumen you should develop. Thank you.
Thank you very much, Hemanandini ma'am, Perinagi ma'am, and Padmapriya for the wonderful discussion. Thank you, Dr. Suganya. We move to the next case.
Thank you.
The next case is ptosis. The presentation is by Dr. Lavanya from RAO-GOH. The examiners will be Professor Yogeshwari ma'am, who is the head of the Orbit and Oculoplasty department in GOH. And we also have Dr. Sendilnathan sir, who is an eminent Orbit and Oculoplasty surgeon in Chennai.
Good evening, everybody. And this will be an exam point of view. I request Dr. Lavanya to present the case. Good evening, sir. Sendilnathan, sir. Nice meeting you, sir. Lavanya?
You can start your case. Yeah. Be very crisp.
Ptosis will be an exam case. Usually for MS, it's a short case. So if you get ptosis, you are lucky that it's a straightforward one and you can handle cool. Am I right, Sharmi?
Yes, ma'am. So with your tips, I think they'll be cakewalk for them. Lavanya, are you ready?
Yes, ma'am. Yes, ma'am.
Yeah, please
Good
go ahead.
evening, all. I'm Dr. Lavanya, postgraduate from RAO-GOH, Chennai. I'm going to present a case on ptosis, chief complaints, A 65-year-old male came to the OPD with complaints of drooping of both upper eyelids for the past 2 years. Drooping of both upper eyelid present for the past 2 years, which is gradually progressing with no history of double vision, no history of trauma, no history of diurnal variation of the drooping of the eyelid, no history of dysphagia or dysphonia, no history of frequent and excessive eye rubbing was present. Past history, known case of type 2 diabetes mellitus for the 4 years on regular treatment. No history of ocular surgeries or lid surgeries in the past. No history of food or drug allergy. Personal history was normal bladder and bowel habits. Family history was nil relevant. General examination was found to be normal. Ophthalmic examination, head posture, chin lift was seen. No obvious facial asymmetry was seen. Visual acuity, the examination of the right eye, visual acuity 6/9 partial with pinhole improved to 6/6. IOP by Goldman applanation tonometer, 12 millimeters of mercury. Lids, there is upper lid ptosis was seen. Conjunctiva and cornea were clear. Anterior chamber normal depth, iris color pattern was normal. Pupil was 3 mm, reacting to both direct and consensual light reflex. Lens, early lens changes were seen. Extraocular movements were full and free. Coming to the left eye, visual acuity 6/12, not improving with glasses and pinhole. IOP was 14 millimeters of mercury. Lids, upper lid ptosis was seen. Conjunctiva clear, cornea clear, anterior chamber normal depth. Iris color pattern was normal. Pupil was 3 mm, reacting to both direct and consensual light reflexes. Lens, grade 1 nucleus sclerosis was seen. Extraocular movements were full. Ptosis evaluation, right eye, the vertical palpebral height was 8 millimeters. Marginal reflex distance 1 was 0. Marginal reflex distance 2 was 8. Lid crease was high. Levator action was found to be 15 millimeter, which is normal. Frontalis overaction was present. Lid lag was not seen. Bell's phenomenon is intact. Fatigability test and ice pack test were negative. Corneal sensation was found to be intact. Schwimmer's test was normal. Extraocular movements were full and free. Left eye ptosis evaluation, vertical palpebral height 6 millimeters. MRD 1 minus 2 millimeter. MRD 2 8 millimeter. Lid crease was found to be high. Levator action was 10, which is good. Frontalis overaction was present. Lid lag was absent. Bell's phenomenon was intact. Fatigability and ice pack test were normal. Negative. Corneal sensation was intact. Schwimmer's test was more than 15 millimeters. Extraocular movements were full and free. This is the picture showing vertical palpebral height. Pictorial representation of right eye and left eye. Fundus examination, both eye, media was clear. Disc CDR 0.3, margins well defined. Vessels were normal. Maculofoveal reflex was present. Fundus examination was normal. Systemic examination was found to be normal. Summary, 65-year-old male, complaints of drooping of both eye upper eyelid for past 2 years, gradually progressive. Examination showed presence of chin lift with no facial asymmetry. MRD1 of right eye was 0, left eye was -2. Vertical palpebral height was 8 mm and 6 mm in right and left eye. Both the eyes have good levator action. High lid crease was seen. Lid drop and down gaze was seen. Intact Bell's phenomenon was seen. My diagnosis, both eye, severe upper lid ptosis with good levator action, most probably of aponeurotic etiology.
Is it congenital or acquired, ma?
It is acquired, ma'am.
Acquired ptosis, probably of aponeurotic.
Aponeurotic etiology.
Instead of directly going, you can give a differential diagnosis, right? What are the points to say aponeurotic you have highlighted? What are the other differential diagnoses you would like to offer?
It's a bilateral ptosis. The first differential would be myasthenia gravis, bilateral third nerve palsy, myogenic causes like myotonic dystrophy, and CPU.
What are the points against these?
Myasthenia gravis, usually it will be a acute presentation. Patient will have a diurnal variation, worsening in the evening after prolonged work. Myasthenia gravis is ruled out. Myotonic dystrophy usually starts in a childhood, and other signs like gripping in the fingers will be there. CPEO is usually symmetrical.
Yeah.
Ocular myasthenia, the patient will have ptosis with symmetrical ptosis. Here the patient is having asymmetrical ptosis. There will be
What are the
diplopia and
tests?
ocular myasthenia.
How will you differentiate between those two?
Ocular
you-
myasthenia.
What is
The
common
clinical test.
is?
Clinically, we can test myasthenia gravis with fatigability test and ice pack test. Fatigability test is negative in this patient. Ice pack test is also negative.
Okay.
Pharmacologically, we can go for tensilon test.
What is tensilon test?
Tensilon test is
See,
to
this
see the
is the
improvement of-
lead you are giving the examiner. If you want myasthenia to be discussed in detail, we can go. Else, you can offer the other differential diagnosis.
Yes, ma'am.
What do you suggest?
Tensilon test.
Tensilon test. You want to go in the direction. So, what are the other types of myogenic doses? What are the other causes?
Myogenic other causes. One is myasthenia gravis, myotonic dystrophy, ocular myopathy, chronic progressive external ophthalmoplegia.
Can it be chronic progressive external ophthalmoplegia here?
No, ma'am. Here the patient extraocular movements were full and free. Only the ptosis was seen, ma'am. And it is here the patient is having asymmetrical ptosis. Chronic progressive external ophthalmoplegia, the ptosis will be symmetrical.
So you want to stick on with the diagnosis of aponeurotic.
Aponeurotic etiology, yes, ma'am.
So how will you differentiate a congenital ptosis from acotiosis? Typical exam question.
History-wise, the patient will be having since birth in congenital ptosis, acquired cancer, late onset ptosis. On examination, the patient will congenital ptosis. The patient will have absence of lid crease with a poor levator function. In acquired ptosis, in this case, aponeurotic ptosis, that will be a high lid crease, high position lid crease. With
Why do you
thin
have a high position lid crease, high tarsal fold? Why do you
The
have?
aponeurotic ptosis is due to dehiscence or stretching of the aponeurosis, ma'am. So,
Do
which
you
increases
have a
the
thinning there?
yes, ma'am. Thinning will also be seen due to the dehiscence or stretching out of the aponeurosis. Yes, ma'am.
And what are the other findings?
And on down gaze, there will be the lid drop, ma'am. The vertical palpable height will be lesser than the normal in down gaze.
Why?
The dehiscence will cause extension of the aponeurosis, which will cause lid drop on the down gaze, ma'am.
Congenital, how will it be?
In congenital, the vertical palpable height on down gaze will be more than the normal side because the dystrophic levator palpebris superior fails to relax on down gaze.
So, sir?
Yes, sir. Yeah, do you want me to ask a few questions?
Yes, sir. Sure, sir.
Yeah. Excellent presentation by Dr. Lavanya. I think you have trained her very well. She's come fully prepared, huh? So, very excellent presentation. All the correct points she has noted. Only thing what I saw is what is the difference between MRD1 and MRD2?
Sir, MRD1 is measured from the corneal reflex to the upper lid margin in the pupillary zone.
Okay.
MRD2 is a corneal reflex to the lower lid margin, sir.
Lower lid, okay.
In the pupillary.
Yeah, in your presentation, you put the left eye, the ptosis is more than right eye.
Yes, sir.
So the vertical palpebral fissure height is 8 millimeters in the right eye and 6 millimeters in the left eye.
Yes, sir.
Okay. And but how come the MRD2 is same in both eyes? You just see your MRD2 is 8 millimeters. How can that be? So your MRD, the VPH, the vertical palpebral height is asymmetrical. One eye has got more ptosis than the other eye.
Yes, sir.
How can there be varying MRD2s? The distance between how can there be same MRD2s? Because MRD2, like you said, is the distance between the lower lid and the corneal right reflex.
Corneal reflex.
Okay,
yes,
and
sir.
in the left eye, you're saying MRD1 is actually -2. That means
Yes, sir.
what do you mean by MRD? 1 is -2 means what do you mean by that?
-2 means the upper lid margin is below the corneal reflex. 2 millimeter is the.
How do you know it's 2 millimeters below the light reflex?
I
Because
retracted the upper lid.
exactly, yeah.
How
So,
much 2 millimeter retraction is required to see the corneal
required to
reflex?
see the corneal light reflex, exactly.
Yes, sir.
But then how can you have same MRD2s? MRD2 in
Sir,
both eyes is 8. Unless there's only one possibility how they can have a same MRD2 with varying MRD1. What is that possibility?
So here the patient had the corneal reflex was within the upper lid margin. So I have retracted the upper
You're
lid margin
retracted
and
by 2
measured.
millimeters.
Then
Okay.
I measured MRD2, which was
Okay.
8 millimeter.
Okay.
Uh,
Okay. Anyway, you're saying that you refracted the lid and then you measured MRD2.
yes, sir.
Okay, that is
Yes, sir.
acceptable. Yeah, that's fine.
Yes, sir.
Because
Yes, sir.
usually it would be better if you don't actually put MRD2 in your exams, because when clinically, when we make decisions on what treatment to do and everything, we don't
Yes, sir.
actually really indicate that MRD2. Because
Yes, sir.
MRD2 actually tells you the position of the lower lid in response to the light reflex. So unless
Yes, sir.
the patient has got a lower lid retraction or inverse ptosis, like what you have in, when will you get inverse ptosis? What is inverse ptosis?
Inverse ptosis is sagging of the lower lid.
Is it sagging of the lower lid?
Or reverse.
What do you mean by ptosis? Is what is ptosis?
Ptosis is drooping
of the upper lid. So what should
upper
be
lid.
inverse ptosis?
So upward positioning the lower lid.
And that's what, if you put MRD2, all these questions and all will be forced to ask. So better you avoid MRD2. Inverse ptosis is actually the lower lid will go up. Lower lid will go up. That is called inverse ptosis. So what will happen is the MRD2, that is, see, in your case, you can't see the light reflex in the left eye. So it's a little complicated. But if the patient has got, let's say, a moderate ptosis where you can see the light reflex, suppose MRD1 is 1 millimeter or 2 millimeters, then the MRD2, depending on the position of the lower lid, becomes important. Suppose the patient has got an inverse ptosis, what will happen is the lid actually goes up. So the distance between the light reflex and the lower lid will be asymmetrical. In both eyes, it will be different. In which condition you will get inverse ptosis? There's only one condition where you get inverse ptosis. What is that condition?
So I'm not sure. In ophthalmos.
No, ma. What are the acquired causes you analyze? You will come to that.
Yeah. What are the common causes of ptosis? Like you said, congenital, aponeurotic. What is one common neurogenic cause of ptosis?
Sir has given the clue also.
Yeah, neurogenic.
Third nerve palsy.
Third nerve palsy. Okay, then.
Horner syndrome.
Exactly. Horner syndrome. Horner syndrome is when you will get an inverse ptosis. So what will you get in Horner syndrome?
Horner syndrome, mild upper lid ptosis, enophthalmos, meiosis, anhidrosis on the skin.
Good. Okay, and then you also get inverse ptosis.
Okay, sir.
So I think your presentation is extremely good. I think you covered everything correctly. So you, like you said, this looks more likely to be a aponeurotic ptosis.
Aponeurotic ptosis,
because the lid crease height. Sometimes, if you want, you can also measure the lid crease instead of just saying it's high or low or normal. You can measure it from the lid margin to the lid crease. Because what is usually the normal lid crease in a normal adult male?
So 10 to 12 millimeters.
That could be in a female.
Female.
Who will have high lid crease?
Female, sir.
Females. Males usually have low lid crease. So usually it's 6 to 8 millimeters in male. In female, it is more high, maybe 10 or 11 like that. So if you have a high lid crease in the male, it's very likely that he's got aponeurotic dehiscence. So it's a good idea if you can measure the lid crease. That gives you more information. What is the lid crease in both eyes? Whether it's that's very, very important, because when you do ptosis surgery, you want symmetrical lid crease heights. That's very important, because you can have good correction of the ptosis. But if you leave the patient with asymmetrical lid crease heights, that actually will not give a very good cosmetic outcome. So lid crease height is again very important, because you have to match it. Suppose the patient has got a unilateral ptosis, other eye is completely normal. Then you can actually determine, you can control where your lid crease is going to happen on the other eye, depending on what is the lid crease in the normal eye. Suppose the patient got 8 millimeters, you can
Yes, sir.
give lid crease exactly at 8 millimeters. Suppose you got 10, you can give it at 10. Suppose the patient has got at 8 millimeter lid crease, and you give him a 5 millimeter lid crease in the other eye, though the lid is lifted well, you'll have asymmetrical creases which was not acceptable to the patient. So, indicating the exact height of the lid crease is something which you need to do. MRD2 is something which you don't need to do, because you, like
Okay.
Madam was saying, you will take the discussion in a different way, which is not very, so that you can actually avoid. Apart from that, I
Yes.
think most of your thing is good. One thing which I'd like to dispute is myasthenia gravis is not a pure myogenic. What is myasthenia gravis? It is a
Autoimmune.
autoimmune. What is the, where is the pathology?
Pathology.
Pathology-synaptic cleft.
Exactly. Is it in the muscle, actually?
No, sir. It's a
It is
neuromuscular junction.
exactly. It's neuromyogenic. It's neuromuscular
Neuromyogenic.
junction.
Yes.
The muscle actually
Yes,
is
sir.
normal. If you
Yes,
give
sir.
that patient oral medication, he will start to function normally, unlike
Yes,
like
sir.
CPEO or ocular myopathy.
Right.
Other thing what I saw is you said oculomyopathy and age, there was a comment. In which age group is oculomyopathy common? In which, like for example, myotonic dystrophy. In which age group do you get patients with myotonic dystrophy? When do you get CPEO? Is there a age difference between the both?
Myotonic dystrophy onset is in the childhood. CPEO is
No, it's
adult.
exactly the reverse. Exactly reverse you're saying. CPEO actually it happens in adolescence. Why actually CPEO sometimes you don't get you don't get patients reaching adult age? Why is it? What do you get in CPEO?
Patient will not have diplopia.
No. What do you get in? What is the systemic association of CPEO?
CPEO mitochondrial disorders, cancer
Disorder.
syndrome.
Okay.
I said.
Exactly. Kern syndrome. What will they have? Systemic.
Retinoid.
Systemic association.
Cardiac conduction
Exactly. They have
abnormality.
cardiac conduction abnormalities. So most of them, they will have serious cardiac problems. So that is why they actually sometimes may not reach to the adult age itself. They have arrhythmias, and sometimes they may need to have pacemakers inserted, all that. Sometimes it's not diagnosed unless you know this condition and you put them on to a cardiologist. They may not get diagnosed. They might suffer a cardiac incident and die early. So on the contrary, myotonic dystrophy usually comes after adult age only. When you see clinically, most of these patients are 50 plus. And they have what type of cataract do they have? Myotonic dystrophy. They have a very specific type of cataract. What is it called?
In December.
Christmas tree cataract.
Exactly. Yeah, you have a Christmas tree cataract type pattern in myotonic. So in which patients develop cataract? Will a patient in 20 years, 15 years develop cataract? He will not.
No, sir.
So myotonic ocular, all this myotonic dystrophy, all that comes slightly with adult age. CPO you get in adolescents, juveniles.
Adolescents, okay.
Yeah, so that is one thing. Apart from that, I think you've done an excellent presentation with all the right the things you've covered. Corneal sensation also you've covered, corneal sensation. Tear film, have you measured? Schirmer's also measured.
Schirmer's, yes, sir.
The only thing what you have to discuss is the treatment. That is the only thing. How will you treat this condition? What will be the procedure of your choice?
This patient is having bilateral aponeurotic ptosis.
Okay.
The procedure of choice is levator resection with the levator aponeurosis reinsertion.
Okay. Very
See,
good.
what is the basic pathology here?
Aponeurotic stretching or dehiscence.
Yeah.
Now tell the treatment.
The patient is having good levator action. So aponeurosis should be reattached to the tarsus.
Exactly. So the treatment of choice is usually levator reattachment. Reattachment itself will be more than enough. You don't need to do a resection. When will you do a resection?
In moderate ptosis.
Yeah. So in moderate ptosis with moderate LPS action, usually in congenital ptosis, when you feel that the levator action is around 10 or 12 and patient has got mild or moderate levator function, then you will try to do a maximal levator resection to try to shorten the muscle as much as possible and see if the lid goes up. Whereas in aponeurotic ptosis, the levator muscle actually is normal. Only there's a dehisced aponeurosis because it's detached from the tarsal plate. So if you just put it back onto the tarsal plate, you will have very good results. You don't need to, if you do resection, what will happen? If you cut a lot of levator, exactly, you will get a overcorrection. Very common. Very common because the levator is already they got good to excellent levator action. No, if you cut the normal levator, what will happen is they'll go in for a overcorrection. So that you have to be think. And what will be the choice of a correction? Will the patient has got bilateral ptosis? So how will you handle it? Will you do bilateral surgery or you do unilateral surgery one by one?
The ptosis is symmetrical. We can go for simultaneous surgery, sir. Asymmetric ptosis, we can go for the versus eye, then followed by the good eyes.
What is the advantage of that?
To achieve the symmetry at the end of the surgery.
Yeah, to achieve symmetry at the end of the surgery, which is better, doing it separately one by one or doing it at the same time? When will you get symmetry? When
doing at the same.
Exactly. When you do it at the same time only, you can match it.
Yes, sir.
Because what will happen if you do it separately? Once you do one eye and you lifted it beautifully, when the other eye is still ptotic.
Yes,
okay.
Sir.
So what will happen when the second stage, when you lift this eye, what will happen to the other eye?
Other eye, we will go for ptosis, sir.
What is that law called? Due to what law?
Herring's law of
exactly. So you're telling all the answers yourself. So that is why you should not, in bilateral ptosis, especially in levator pathology, you're not supposed to do in separate sittings. Because what will happen is when you do one eye, you will get a very good result in that eye. But the other eye will be ptotic. In fact, you will increase the ptosis on the other eye because you lifted the one eye, other eye will become more ptotic. And the second stage, when you lift the second eye, the eye which you operated will drop.
Yes,
so that's actually very difficult to treat unless you leave the second eye undercorrected. No, you very hard to get symmetry. So better in all these levator aponeurotic ptosis, it's always a good idea to do it in the same sitting.
Yes, sir.
That's very important. So,
yes, sir.
Yes, madam, you can, excellent presentation, madam. She's done extremely well.
Yes, sir. Thank you, sir. My student.
Yeah.
Thank you.
When I saw the history itself, I guessed it. You must be, you must have guided her. Very elaborate.
Very good presentation, Dr. Lavanya, and thank you, Sandil Nansar and Yogeshwari ma'am for the wonderful discussion.
Thank you,
Yogi ma'am, you want to give any
Nirmal,
concluding remarks, ma'am? Yogi ma'am?
Yes, ptosis in exam point of view is actually a boon for the students. But you have to approach it methodically, especially when aponeurotic ptosis. You please tell whatever is needed in the exam. Like if you want to guide in myasthenia or myotonia dystrophica, please guide in that direction. Else you stick on to your aponeurotic ptosis. And as sir said, if you are very clear, stick on to margin reflex distance, margin crease distance, levator action, and a good summary with lid position and how you will go about managing will suffice. It will be a 7 minutes time in a short case for the candidate to be analyzed. In that 7 minutes, if you stick on to the important points, it will be a good opportunity to go to score in the exam. So other types and congenital ptosis, usually when kept, also you go methodically and approach like lid crease absent, highlight the salient feature like levator action poor, and hence I'll go for sling surgery. I will look for bills and shimmers. These very important points is what we expect from the postgraduate MS or dependent as an examiner point of view. So coolly
Thank
take
you
the
very
exam
much,
with points. Thank you, Sharmi and
thank you very
Sharmila.
much, ma'am.
Thank you, Nirmal sir.
Thank you, madam.
On behalf of TNOA, it's my pleasure to propose the vote of thanks. Nirmal sir had some network issues and he couldn't join us. The later part of the webinar, he was not able to join us. Thanks to Dr. Suganya, Dr. Sushmita, and Dr. Lavanya for the wonderful presentation. They're all brave hearts and they answered very well, very good documentation. All the 3 cases were well documented and very nicely presented with the guidance of the teachers. Thanks to the examiners, Professor Vijay Shanmugam sir, Preeti Uday, Dr. Preeti Uday, Professor Hemanandini madam, Professor Perinaigi madam, Dr. Padma Priya, Sendilnathan sir, and Professor Yogeshwari ma'am for the expert guidance. All these webinars are available on YouTube, and these YouTube videos will serve as ready reckoners for you whenever you present a case. So we wind up with the third session of this postgraduate update program, and every program has about more than 1,000 views. So please refer it if you want to present a case. We look forward to seeing all the postgraduates in the TNOA Gurukulam, which is going to be conducted in association with Madurai Ophthalmological Association and Madurai Aravind. So see you there on Sunday. Thank you very much. And thanks to the technical support team, Sai sir and Manjula ma'am from Numerotech. Thank you very much. Good night.
Thank you. Thank you.
Thank you.
Good night, sir. Good night.